Good afternoon and welcome to our Lunch Chats, Keeping You Healthy web series. My name is Krista Deans and I manage public relations for San Ramon Regional Medical Center. For today's presentation, we have the pleasure of introducing Mandee Starn. She's a speech therapist here at the hospital, and today she's going to discuss speech therapy for chronic cough and voice disorders. Thanks so much for joining us today, Mandee.
Thanks for having me, and thanks for the opportunity to talk today about chronic cough and speech therapy and a little bit about voice therapy. As you mentioned, I've been a speech therapist here at San Ramon Medical Center for about 12 years and in the medical setting for a little over 20 years. And my specialty is in upper airway and voice disorders within the speech therapy world. And I am excited to talk today about I am not able to share my screen here.
So I can see your screen. I wonder if you're able to start clicking through.
Yeah, that's what I'm trying.
Okay.
There we go.
Perfect.
Can you see it okay now?
Yep, I can see
All
it.
right, so there we go. So I am happy to be able to talk today about chronic cough. And the reason is that it's fairly misunderstood and it's also fairly common. And there's a lot of patients that I see that suffer kind of needlessly. And I'd really like to get some information out there today to help those patients or potential patients, because a lot of people are just going through their world untreated right now. And unfortunately, it cannot be cured by chocolate. That would be the best, as this indicates, but no such luck. But there is hope, and it's through speech therapy. And so I'm going to start by just kind of defining what is chronic cough and throat clearing. And I kind of use those terms somewhat interchangeably because the mechanism, what the body does when we cough chronically or clear our throat chronically is essentially the same. It's just kind of varying degrees of what we're doing. And the technical definition of a chronic cough is a cough that in adults will last for more than 8 weeks, or in children that will last for 4 weeks, and or is just not responding to medical intervention. It has a whole host of other names. So patients may have been told, oh, you've got an unexplained cough or an idiopathic cough, refractory cough. All of those things are essentially a chronic cough. What it's not is going out to dinner and having a hamburger and feeling like, oh, it's going down the wrong way. Now I need to cough and get that burger or what have you out. That's an acute incident where our body is telling us something's going in the wrong spot. I need to cough to make sure that that does not get into my lungs, to my airway, into my lungs. And that happens once, or it happens twice, or hopefully not every time you have a meal, but it happens on occasion to everybody. That's an acute incident. A chronic cough is one, like it says, it goes on for quite a while. And it can be triggered by eating. It can be triggered by a whole host of things, many of which are listed there to the right. But that just because it's triggered by that, it continues to go on beyond the extent of the trigger. And we'll kind of talk more about that and what I mean by that. But it's something that happens over and over and over again. And my patients are often the ones that will say, or their family will say, oh, we always know when dad is coming, or we always know when so-and-so is coming. We hear him coming before he gets here, or we hear her coming before they get into the room, because they're constantly all day long, or they're coughing all day long. And why do we care? Well, we care for two big reasons. One, because it can have some pretty devastating and significant life impacts. And two, because it's pretty common. So kind of taking that first part here, why we care. Obviously, like any medical condition, it can exist on a spectrum of severity, right? So it can be a minor nuisance to some people, where they're kind of noticing, or their family members are annoyed more than anything, to a very severe situation where I will have patients coughing literally hundreds of times within an hour, or clearing their throats hundreds and hundreds of times. So anything on that scale can happen. The problem is we might start over here where it's a nuisance to our family members, but the more we cough, if it's a true chronic cough, the more that begets more coughing, right? The more we cough, the more likely it is that we will continue to cough, and that the system that's making us cough will just be reinforced rather than having it extinguish or go away. And the result of that chronic coughing can, like I said, have implications across many aspects of an individual's life, including professional implications. In the Bay Area, we have a lot of professionals, a lot of executives who are chronically coughing and are unable to make it through a Zoom meeting, or unable to make it through, I have teachers who can't make it through a day of teaching without excusing themselves repeatedly to go cough. And it can be very disruptive for them. Obviously, it can have social implications. I've had a number of patients that over the years have stopped going to theater, stopped going to religious services in fear of interrupting the service or the production or what have you. And certainly over the last year and a half, a number of my patients that are chronically coughing are experiencing social isolation, and being viewed suspiciously every time they leave their house because of COVID. People are thinking that they are, spreading COVID, when in fact they've been coughing for a decade or more, and it has nothing to do with COVID. So it can have social implications. Obviously, in the most severe cases, we can pass out, and I have patients that have passed out while driving. And again, this is very severe, and not everybody exists at that level, but that is what can develop with chronic cough over time. Sleep disturbances, incontinence, and of course, voice disorders. Coughing is not good for our voice. Our little muscles that sit at the top of our windpipe are called our vocal folds, and they really don't appreciate us coughing all the time or clearing our throat. And that can change the way we speak, and ultimately have impacts not just on speaking, but swallowing as we age in particular. So it can be pretty devastating across a number of different life situations, and it's fairly common. 9% of the population worldwide and 12% of Americans and Europeans will have chronic cough at some point in their life. And it is responsible for a significant number of physician visits each year, as you can see there. And probably the most frustrating for the patient that experiences chronic cough is that these patients will go to, many of them will go to multiple physicians over and over again and not be able to get any relief. And they'll get many, many medications. So over half the patients see over 4 physicians and have at least 6 medications before they end up going to a speech therapist. Who do they see? Well, they usually most of my patients end up going first to their primary care physician to say, hey doc, I've got this cough, it's not going away. Can you help me out? Tell me what's going on. And oftentimes that primary care physician is trying to figure out, well, what's the root etiology? What's the primary cause of the cough? And so they may give you an inhaler right there, thinking that it's a pulmonary issue, or they may send you to a pulmonologist who's going to look at your lungs, or a laryngologist, and that's just a doctor who's an ear, nose, and throat doctor who specializes in the throat, or an ear, nose, and throat doctor. If they think that there's a GI issue, a gastroenterologist would be referred to. Allergies are often suspected for good reason, so you may go to an allergist or possibly a neurologist. So any one of those primary care physician on down to specialties is who patients will typically see. And as I said, the goal of these physicians is to figure out, well, what's going on? What's the cause here? And we can start a cough for a whole bunch of reasons. As we talked about, it can be an acute situation where the food is going down the wrong way, or it could be something that we have a little postnasal drip, and the postnasal drip starts here in our nasal area and drips down the back of the throat and irritates here in our throat. And we may feel like that, I have phlegm in there, I have something there I need to clear. That's very common. It can be related to reflux. So we've got some stomach issues and we feel we've got some heartburn, and that reflux then comes up through the esophagus, the tube that goes into our stomach, and also can end up with little acids coming right all the way up to our top of our airway. Another thing that the vocal folds don't like, and they may react to it and say, oh, I need to cough. Obviously, smoking can cause coughing. Some medications particularly those that are used for high blood pressure, which doesn't mean you should stop taking your medications, but definitely talk to your doctor about, are there alternatives to the medication you may be taking if that's the issue. So there's a whole bunch of reasons all listed there that we might start the chronic cough. The issue ultimately is that the physician is going to approach it from a medical standpoint, as they should, and look at, okay, if this person has reflux, let's go ahead and let's treat the reflux. If the person is smoking, let's help them stop smoking, right? If they have allergies, let's treat the allergies. So all of those treatments that are at the physician's disposal are really designed to control the underlying cause, which is great. We want to do that. Unfortunately, about 36% of patients report that none of the medications that they are given do anything. No inhalers, they just don't do anything. And what I mean by they don't do anything means that they don't improve the cough. They might be helping with the underlying condition. They might be helping with manage the reflux. They might be helping manage the allergies, et cetera, but they don't ultimately help reduce the severity and frequency of the cough and the disruption that causes them for the patient. And it's not because the physicians have failed. They've treated what they've been trained to treat, and that should be also giving you health benefits. But the issue is that there's been a change, that the system, the body's system, no longer is reacting to the original stimulus, meaning that if you started to cough because you had a little postnasal drip and it got here and it started irritating your throat, maybe that happened a few times, but over time, the more you've coughed or more an individual has coughed, the receptors, we have little cough receptors that sit in the top of our throat, become kind of hypersensitive, such that you no longer need a certain level of stimulus for the brain to get a message that you need to cough. And so no amount of medication can change that piece of it, right? That it becomes a message from your throat to your brain. And so that is where speech therapy comes in. And we can see that about 80% of folks actually improve with speech therapy. And the really great thing is, we're not poking and prodding you, no needles, no medications. It's all about teaching you how to do this and how to rewire the brain so that you don't need to cough. There's one thing on the prior slide. I'm gonna see if I can go back, actually. I'm going to come back to this. The last one there, it says nerve injections with a laryngologist. We're going to address that kind of separately at the end, as in terms of medical, a medical intervention. But first step really should be through speech therapy. And the earlier a patient gets into speech therapy, the better their outcomes. And why is it? Why can speech therapy help? Well, we work on the lose it part of use it or lose it, meaning that our job is to help you kind of rewire the system to allow you to change that experience of every time a very minimal level of stimulant gets to your throat, that you experience it as a minimal level and not as I need to cough. I often talk about to my patients that, you know, the loved ones will say, can't you just tell him to stop coughing? If it's under his control, why can't he just stop coughing? And it's a little bit like, you know, telling somebody who has poison oaks, don't scratch, right? We can resist, but it's really hard. We really want to scratch that itch, right? But if you do certain things, you cover the patch of poison oak, and you know, put something on it that reduces the itch, we can stop itching it. We have some control over our ability to stop itching it, and over time it heals. Kind of analogous to that, right? We need to have some strategies to stop coughing so that we can rewire our system. So we work on the lose it part. We're going to teach you how to not cough so that the brain can kind of rewire itself and these receptors can go back to normal. And how do we do that? Well, We start out with an assessment. So a patient will come in, and our job really is at this point to hear your story, to hear the patient's story, to understand when did the cough begin, how severe is it, what have they tried that's worked, what have they tried that hasn't worked, what are their triggers, meaning that do you cough every time you laugh? Do you cough every time you exercise? Do you cough every time you walk into a room and you smell somebody with perfume on? Do you cough every time you eat pepper, or drink warm things or drink cold things? There are all of those kind of mechanical and thermal stimulants that can end up inducing a cough. And the patient experiences those as a very strong signal that they must cough, even in the case when it's barely anything is there. So their experience still stays as a normal individuals would, but their receptors, because they're so hypersensitive, are giving them the wrong message. So our first step is to understand their story. Our second step is we do a few assessments. We're going to watch how they're breathing. We're going to watch, we're going to have a look at their lips and their tongue and their face, make sure that all that piece of the apparatus is working well. We're going to check on their voice because, as we said earlier, chronically coughing is basically slamming your vocal cords together over and over again, and they don't like it. And so over time, they can become very swollen. They can develop lesions. All kinds of things can happen to the vocal folds, which will inhibit their proper use and change the way we sound. And ultimately, it can also be related to how we swallow, as we talked about. And then finally, we'll do some perceptual assessments. So these are just surveys trying to get a sense of what's the impact of the cough on the patient's life. And so that's the first time we meet. And then after that, we do some therapy. And therapy has kind of these different 4 parts. And it's not sequential. All of those components are built into each of the therapy sessions. But basically, you could plan on kind of coming in and meeting with your therapist once a week for 3 to 4 weeks, and you're going to hit on all of these things. We're going to work on trying to make sure that we properly educate the patients and really give them the information they need to empower them to stop coughing or clearing their throat. We're going to help them rehabilitate the system. And we work on motivation and counseling and all kinds of other pieces that are listed there. We may also need to assess and treat kind of what we call comorbid deficits or issues, meaning that other things as a result of the cough can happen, as we've talked about. So very common to get swallowing, breathing, and voice disorders as a result of chronically coughing and throat clearing. And so in that case, we'll look at those and try to help the patient as appropriately. So the first piece of treatment is the education component. And I usually ask patients on the first day, well, if you were to cough 100 times a day, about how many of those coughs do you feel like are just out of your control? They just happen. There's no way that you had any signal that they were going to happen. They just happened, reflexive. And usually it's somewhere around 50 to 70% of the time, the patient doesn't even realize that they're coughing or has no kind of something's coming. But at least one group of coughs for every patient exists in this other bucket, right? The coughs that we have some kind of warning, they're coming, we have a tickle in our throat, something's about to happen. And that's the group of coughs that we target first, right? We target those and we try to give the patient some strategies on how do we eliminate those. And by eliminating or reducing those, the ones we have some control over, then that other bucket of coughs, the ones that, oh my gosh, I didn't even know it, I coughed, or I didn't even have any warning, they will also start to go down. And they start to go down because that nerve starts to relax. We don't constantly stimulate it. And that's kind of how it works. And the chart there on the left is kind of nice. It shows that on the x-axis, kind of the degree of stimulation and the degree of how much needs to be stimulated in the throat for a normal patient to get a message to their brain that they need to cough versus what someone who's been chronically coughing needs. So very limited amount of stimulation is needed before they get a message that they need to cough. And remember, they still experience it as that normal patient getting a full load of "I must cough now." And what we're doing with our treatment is trying to kind of, again, educate the patient, help them understand that this process is a vicious circle, that the more we cough, the more we're going to put other things in place so that we're likely to cough again, meaning that we are likely to aggravate our breathing pattern. We're likely to aggravate our throat. And all of those things will set us up for continued coughing. And the more we cough, the more we stimulate these receptors, the more they want to continue that pattern. And it becomes a pattern. And so we have to kind of break the cycle. And helping people understand that that's what we're doing is the first step in therapy. And we help them by giving them exercises. We really focus on giving this area of our throat other things to do, things that one, are relaxing to the muscles in the throat, or two, are contrary to the motion of coughing. So might have somebody kind of breathe in through their nose, a long kind of slow, easy sniff, and then exhale out a shh sound. And that can actually be very effective in terms of suppressing a cough. But there are a whole host of other things, and it really depends on the patient and their triggers in particular. But the exercises are designed to help the patient have some strategies to delay or inhibit the cough completely. And the strategies don't have to be 100% successful. We don't have to say, here's the magic pill, and every time you do this, then from now on you won't cough. We just have to be successful most of the time for those coughs that the patient has warning around. Because if we can just start this to kind of calm down and get the receptors to calm down, we can start that rewiring process and get the brain to recognize that it's triggering too fast. Okay. And so we teach them a number of different strategies, and they're pretty effective. The thing that I also try to remind my patients about is that this doesn't mean you need to do this forever, right? This therapy should last, 4 to 8 weeks, somewhere in that range. We teach you some strategies. We help you learn them. We start by doing them just in the office together when you don't feel like you need to cough at a particular moment, but then we gradually do them more and more and more in different conditions with more and more triggers around us. And the goal is to rewire the system so that ultimately you can be around your triggers and that you don't need to use this because the brain just knows it's back to what it used to do. It doesn't have to keep using the strategies. So it's intensive, quick therapy that gives people strategies to help relearn a system, but then they move on. This isn't forever. Okay. We also need to recognize that the voice box is often damaged in this process. So we have to treat it like an injured part of our body, which it is often for someone who has chronic coughing. And so we take care of it. And we teach people how to take care of the larynx. We make sure they're breathing in through their nose and not breathing in through their mouth. Make sure that they're hydrating properly. They're avoiding smoking. They're avoiding the things that are absolutely known to irritate the system. So there's some do's and don'ts there, which are pretty straightforward for the most part. We still want to control those underlying situations, right? The reflux or postnasal drip that may have started the whole thing in the beginning. We want to make sure that those things are under control as well, and they're working with their physicians to control those. But we help them rehabilitate this, and particularly for those patients that already have bad voice issues as a result of chronic coughing. We have to make sure that those go away and the voice returns to normal. And then, the counseling piece of it, I have yet to meet a patient who is chronically coughing that really needs much motivation to participate in therapy. Usually they really just want to be done with this. And so it's really not so much about a matter of motivating them, but really giving them the strategies and having them understand fully why they're doing what they're doing and for how long they're expected to do it. And so motivation isn't such a huge deal, although that's considered part of the program. I think the stress issue is a bigger deal for sure, and really looking at our patients as whole patients and whole people, and trying to help them recognize, what in your life is aggravating this. And stress can absolutely aggravate the chronic cough. And so the good news is a lot of our strategies are designed to reduce stress kind of holistically, as well as reduce the stress in this area. And so there's some spillover effect there for a lot of folks. And so that's kind of the final piece of the therapy. My final message is that there's no reason for patients to be out there suffering from chronically coughing and the ramifications that can result in, which is all of those social, professional, et cetera, impact on your life, and physical impact with the change of voice and change of swallow that can happen over time. It's very treatable, and they should definitely go see their physician, talk to their physician about getting into speech therapy, and we'd be happy to help you. No one needs to have chronic cough.
Excellent. Is there one more slide, Mandee? There we go. Well, that was excellent information, and it really does impact so many people, and it just seems that it's one of those topics that we just don't hear a lot about unless it really impacts you. So I think this is just wonderful information. So we really appreciate you coming on and talking about this topic for us.
Thanks for the opportunity.
Of course, and if anyone does have questions for Mandee that maybe weren't addressed today, definitely visit our website and just go to our Contact Us page, and we'll get you in touch with Mandee and make sure that we get your questions answered. So thanks again, Mandee. We really appreciate it.
Of course. Bye.
Have a great day, everyone.